I want to thank Dr. Buxton. I want to thank the partnership for putting this together. As Dr. Buxton said, I'm from Scott & White. I was born a surgeon, that's what I do, but I've been pulled into administrative medicine, and so I am the chief of surgery. I still practice surgery in Round Rock, but now I'm also one of the assistant system chief medical officers for Scott & White, just to give you a little bit of my background. So if you'll indulge me just for a bit, I want to give you some history about Scott & White and what the structure of Scott & White is. Some of you are familiar with the organization, others aren't, and I'll tell you how that relates to how we take care of our patients and how we approach this challenging patient population, to give you a little bit of insight as to what our plans are in the future. That's okay. All right, let's see if this is going to, where am I pointing here?
Go down.
Down? There we go. All right, so this is Dr. Arthur Scott and Dr. Raleigh White. They were the two that began all of this, and it really was centered around the Santa Fe Railroad, basically. The Santa Fe Railroad system built the Santa Fe Hospital in Temple in 1891, and so it was an employer-based program, essentially at that time, to care for the railroad workers. They created a hospital, they needed physicians to staff that hospital, and they needed a chief of surgery, and so Dr. Scott, after some cajoling, a couple of different offers, he eventually agreed to go to Temple from Gainesville and become the chief of surgery. And he remained the chief of surgery actually until he died in 1940 at the Santa Fe Hospital. Not long after starting that practice, he needed a second surgeon, and so he held a series of interviews and actually gave tests. And Dr. Raleigh White was the one that scored the highest score on the test, and Dr. Scott chose him to be his partner. While they were practicing at the Santa Fe Hospital, because that was just limited to the railroad workers, they also began a private practice, and not too long after that they became busy enough that they needed a hospital to practice in that was outside the Santa Fe Hospital. And not many people know it, but if you're familiar with Temple, you're familiar with King's Daughters Hospitals, but Dr. Scott and Dr. White actually founded King's Daughters Hospital in 1898. They stayed with that practice in that hospital for about 6 years. Eventually it became big enough and they didn't have enough room just for their own private patients and also for their charity patients that I'm sorry, we're going backwards. They opened the Temple Sanitarium in 1904 and expanded that over the course of the next 10 years, basically, to eventually what would become Scott & White Hospital. Now, there certainly was charity care back then. There were patients that were unable to pay for their care, and that was covered, similar to how it is today, with some basically funding from private pay patients. So they had a private pay service, basically. They took those funds, and they certainly took care of all charity care that came their way. Interestingly, they would provide free care for ministers and their families. They would provide free care for healthcare workers and their families. And they gave credit initially on the honor system. There was a handshake, basically. So they had a lot of farmers who had cyclical revenue, basically, and so they would extend credit to those individuals and other business owners as they came into the hospital, and that was expected to be paid back with no contract, just, again, a handshake. Now, it's interesting to note the business manager at that time, Fred Stroop, said that until the inception of the automobile and people sort of trying to make bigger purchases than they normally would and not necessarily living within their means, they eventually did have to create a contractual obligation for credit around that time. I found this interesting. So at the end of every year, Dr. White would sit down with the business manager and they would review all of their outstanding debt obligation. And they knew the community, they lived in the community, and so anyone that they felt would create an undue burden to pay back their debt, they would send a receipt paid in full every Christmas and clean those off the books, basically. And so that continued during that time. And Dr. White's philosophy was, if we take care of people, they'll take care of us, and more patients will come to our facility. Unfortunately, Dr. White suffered a heart attack in 1917 that eventually would take his life, and he died in the latter part of 1917 at age 44. By that time, several other surgeons had been brought into the practice, and other practitioners as well, an anesthesiologist, a medical specialist. And Dr. Scott decided to expand the partnership to basically a group practice model, and that's how Scott & White became what it is today in terms of a group practice model. Dr. Scott recommended at that time that they rename the Temple Sanitarium the Raleigh White Hospital, but the board of directors settled on the Scott and White Hospital, basically, and that's when it was named in 1922. They stayed in that building until the mid-1940s and then purchased another 340 acres up on the hill where people were familiar with the location of Scott and White today. In 1949, we were able to achieve our not-for-profit designation that allowed us basically to expand our fundraising efforts and generate the money for the hospital that exists today. In 1958, that Temple Sanitarium was actually becoming quite old, and we were advised to basically create a new building, which we had acreage for, or close down the existing building. And so in 1963, with, again, a good philanthropy, we were able to open the facility on the hill that now exists. That cost of that facility is $10 million, which is sort of mind-boggling because we can't do much for that kind of money today. And so that's where we are and have been for 50 years. So what does Scott and White look like today? Well, it's a much larger organization. We have about 1,300 employed providers, that's physicians and mid-levels. We have over 13,000 employees and cover 32 counties and 25,000 square miles. We either own or manage now approximately 12 hospitals and have other hospitals coming online. We have our own medical school, a 4-year medical school in Temple, basically, and we also have a nursing school. So we're very involved in research and education of future healthcare providers, basically, and one of our big focuses, and what we'll talk about later, is the need that we will have for primary care physicians in the future, the need that we will have for further mid-level providers, and sort of changing the structure of how we care for patients. It's the only way we're going to be able to care for everyone. With healthcare reform and with the aging population, we're going to have to see a shift in how we care for patients. We have our own health plan, which is our insurance product, basically, and it provides us an opportunity to align the organization, and I think that's something that's important to understand. So we are an integrated medical model. When we talk about integration, a lot of people think IT, and that's an important part of our integration, but that's not the only thing we do. The system is aligned from the top with Dr. Pryor, who's our president and CEO, all the way throughout the organization, and that's an alignment of goals of how we manage our patient populations and how we care for our communities. So what does our charitable care look like? This is actually data from 2009, but we had a 177 million, just over 177 million in combined benefits. You can see how that breaks out as charity care, 133 million. Educational support is not the educational support we talked about with the medical school and the residency and those things. It's educational support for the communities, basically, and trying to educate people about how to care for themselves better. We do have research support, and again, that's community-based research, and we'll talk about what that looks like and how it helps. The actual act of doing research in these communities will help these communities take better care of themselves. And then subsidized services or donations to different organizations that are, again, out in the community caring for patients. Again, just to mention our residency, I may have a pointer here, residency and fellowship programs and our medical residents and fellows in training. And then we also have some, this is the accrediting organization for fellowships, but we have some that are not accredited by that group that are fellowships that help, again, people obtain further training. What is the structure of our free clinics, basically? Well, in Temple and Belton, we have the Holland Clinic and the Temple Community Free Clinic. These are staffed with Scott and White physicians and medical students, so it provides an opportunity for education, but again, it also helps people who can't pay for care have access to physicians. They provide, the Holland Clinic is actually set up in an elementary school, and it provides care for teachers and students, but also is open to the community. The Martha's Clinic, or some referred to as Martha's Kitchen, is held in an emergency shelter, and it has a place for lab work, and it also helps coordinate referrals for patients to other physicians. The Temple Clinic basically is a volunteer clinic, and it has also medical supplies and is for the working poor, basically, where They can't have other types of insurance or other type of funding. Basically, it's strictly for indigent patients who can't get access in other ways. We have partnerships with the Lone Star Circle of Care, which some of you may be familiar with. Basically, these are what we call FQHCs, or federally qualified health clinics. And so we partner up in Temple with the Santa Fe Clinic, the Sparta Road Clinic, which provides care for adults and pediatrics. And then also recently formed a partnership in Taylor, east of Round Rock, to provide care in that community. We also have free clinics in Waco and College Station. The partnership with the Belton County Community Needs Coalition, again, this is an opportunity where Scott and White saw that and the Bell County Coalition basically saw that in the future, the community was going to have needs that were not going to be met by our current structure. And so a partnership's been formed to help do an assessment basically of that community and see where we can try to meet those needs in the future. You may have heard the story today. I was touched by a story about the Marine who's going to receive the Medal of Honor, basically, but our military are still very involved in a fight, and young men and women are dying, and then the families that are left behind certainly need help, and we don't like to think of our military as necessarily underserved, but as they integrate back into the community, we have a responsibility to help them with that process, basically, and bring those young men and women back and help them be a part of where they left. So Scott and White's partnered with Triad, or the Texas Resource for Iraq and Afghanistan Deployment. We provide military health services for the soldiers. We provide military health services for the spouses and their families. This is an unlimited service. It's free. It gives them anonymous access, which is important in the community. Basically, a lot of people don't want to admit necessarily that they need help if they don't have a support system, to social workers and mental health professionals. The boot camps refers to a service that's done in communities that have a large number of militaries, basically, or a large number of military personnel, and they're events that help, again, bring those soldiers back into the community and make them feel a part of the community. Looking at some of our research and education, This was a program that was done by one of our infectious disease pediatricians who got a grant, basically. It provided flu immunizations for children 4 and up at their schools, basically, so it went into where the children are to try to raise. There's a couple of goals of this research program, but one was just to increase the number of children that are vaccinated, which it accomplished. But it was really looking at a concept called herd immunity. Basically, is if we vaccinate more of the children, which we did, 10 times the vaccination rate, and we prevent more illness in the children, do we prevent more illness in their families, and do we prevent more illness in the community? And in fact, you do. And so we showed that basically that this herd immunity was something that reduced the number of acute respiratory events, at least the medical visits needed for acute respiratory events. And again, when we look at how are we going to face the future, one of the things that we need to figure out is how are we going to keep people healthier where they don't need health services, or at least acute health services, because hospitalizations, emergency room visits, all those things drive up the cost of health care. And so this is an opportunity to try to reduce those needs. This Jumpstart Get Fit program is again put on by is a grant that was received by one of the pediatricians in Round Rock, a partnership with Williamson County Health District, targeting pediatric obesity, which all of us now are aware that that's a rising problem. And we know those children in the future are going to have increased healthcare service needs and increased comorbidities that are going to cause them to interact in the healthcare system much more frequently. But it targets children above, with a BMI, that's a body mass index, above the 85th percentile for their age group, basically. And there's 2 programs. The Jumpstart is for children with insurance. The Get Fit is for any child, basically. This is done in the pediatrician's office. The Get Fit is done through the health district and in the schools, basically, but it provides intensive courses. So one of them is a 9-week course where they have access to a physician, a nutritionist, health educator. They do physical education, and they have a case manager. So what this accomplishes is basically trying to train not just the children, but their families on how to eat right, how to stay active, how these parents can give their kids the nutrition and the tools they need to reverse the condition that unfortunately we're seeing in these kids at a very early age. Now, the other thing it does, so again, sort of a twofold accomplishment here, is there's a case manager involved in all of these programs. So any child that comes through the program that does not have insurance or is not enrolled in some sort of a government funding so that they can get health care, it picks up those children, identifies them, and gets them enrolled in an appropriate program. And so no child leaves the program without access to health care, basically, on the other end. It also helps the families. It's extended to the families as well, and so it's not limited to just the children. Our patient financial assistance program is something that exists throughout Scott and White, basically, but it's an internal program of charity care that funds medically necessary services up to 200% of the federal poverty level. It fills in a gap that seems to be increasing of this concept of the working poor, basically, but the gap between what Medicaid funds in adults and what the hospitals can fund. And so we see approximately 800 applications a month throughout the system for this need, and most people that apply qualify. We also are a disproportionate share hospital, basically, and Temple at least, which allows us to care for more patients and act as a safety net for that community. So what's it going to look like in the future? And it's difficult to discuss this topic without touching on healthcare reform a little bit, and I'm sure the other speakers will as well, Darren especially. But what does Texas look like now? This is something probably all of us have seen and are aware. In 2009, Texas, unfortunately, was the highest rate of uninsured patients in the country at 33%. The lowest state was Massachusetts with their health care program, and they were at 7%. I've heard it's gotten down as low as 2% now with their mandated insurance. But if we fast forward to 10 years from now, what is it going to look like? There's maybe the perception that we'll be able to get everyone insured. There will still be an uninsured population for a variety of reasons, even with health care reform. And you see Texas is targeted, along with Nevada, to still be one of the higher states in the United States. Okay. So again, this is sort of what we look like today. This is nationwide with 50 million uninsured. In 2019, we expect an expansion of Medicaid, an expansion. This is the health insurance exchanges, basically, that will come online. But we still expect to see an uninsured group. That could be people opting out of the insurance and just agreeing to pay the fines. That could be employers opting out of the insurance program and agreeing to pay fines. So it's not. It will be an expansion of coverage, but it won't expand to cover everyone. And how are we going to deal with those patients? Well, sort of the approach that we're taking is based on Don Berwick, the head administrator for CMS, but the triple aim, basically what he's asked healthcare to do is create a better patient experience, create healthier communities, but do it at a lower cost, and that's a big challenge. I mean, how we care for patients, for more patients for less money, is what we're all focused on today. And it's really about trying to shift the rate of expansion. So are we going to dramatically decrease the amount of money we're paying today? We're probably not. We're going to try to bend the curve, is what they refer to it as, to bend the projections, basically, so we're paying less as we go forward based on the projections. So this is really, my slide didn't align as it was supposed to, but this equation is really kind of where I focus and where we focus, basically, is this value proposition. And what we've tended to believe in the past is that to increase quality, we needed to increase cost. Technology, different programs, expansion of services, all those sorts of things cost money, but if we're not careful how we do that, doesn't necessarily change the quality of care that we provide, and it decreases the value if you look at this equation. So if cost goes up and the patient doesn't receive something for that, we're not helping with the value proposition. So this is kind of just a quick summary of healthcare reform, and I'm not going to spend my whole talk on this, but basically, we're going to see an expansion of the insured population. A large portion of that is going to be Medicaid, and we're expected to reduce cost over a 10-year period and improve value. And if you look at where we're focusing to try to change this proposition, we want to focus on evidence-based practices. Basically, we want to make sure that what we are doing on a day-to-day basis achieves the outcomes that we believe. Physicians are unique in that we all think we provide the best care possible, and that if patients are having bad outcomes, that it's someone else's patient, or that our patients are sicker maybe than someone else's patients. And it's not, there's no maliciousness there. It's just that we've practiced a type of empiric-based medicine that is going to have to change and focus more on evidence-based medicine for populations, essentially, to try to ensure that we get the best outcome for the broadest group of people. You'll see different demonstration projects on different types of payment systems, and I believe we'll move away from a fee-for-service payment system where we are now into quality sort of value-based payment systems, bundled payments, and quality incentive payments. There are going to be big focuses on trying to reduce hospitalizations, because that's where the bulk of the money is spent, and reduce certain imaging procedures. And again, that's not based on just a reduction of services. It's based on, if it's done correctly, it should be based on evidence. Essentially, what do patients need when they come in the door to achieve the outcome that they're looking for? And we're a consumptive society, and so we tend to think more is better. And as a physician, I can tell you there are times where I talk with patients and try to make them understand to the best of my ability that maybe they don't need a CT scan or an MRI, but we tend to believe that if we can get as much as possible out of our healthcare services, then we've achieved our goal, basically. And so those negative imaging studies we think are okay. Well, when in reality what happens is, and you guys have probably all lived this, but when we're looking for one thing, we generally find three others that we weren't intending to find, and we end up doing procedures, and then that sort of goes on this conveyor belt where people end up having outcomes that were not intended to have, based on a test that probably didn't need to be done in the very first place. So these are the kind of changes that we're going to have to really look at to reduce the cost of care that we provide. And again, we've got to increase access. That's something I hope the panel will discuss, but we're nowhere near the number of primary care physicians and providers that we need to service these individuals in addition to the baby boomers. I mean, we just don't have enough physicians, and we're not structured in a way where we can handle this. And so, we're going to have to look at different models, because the current graduation rate of medical students and the number of physicians that are going into primary care is not anywhere near what we need. And so we're going to have to change, again, the structure of how we take care of people. A little bit on, what is the impact going to be on hospitals and physicians? This is, sort of what the payment system looks like today. By far, the bulk of our margins come from commercial insurance, and we're able to sort of shift cost to take care of Medicare patients. If you're a disproportionate share hospital, again, you get some revenue from the state and federal governments to help with this care for Medicaid patients. And then we have our group of patients over here that are charity care, basically. And then we, again, haven't even talked about our undocumented folks that we do care for, basically, because we don't turn people away. So how are we going to achieve this new level, basically? Well, there's a number of different processes, and these are employed at Scott & White. Lean process is something that you guys may be familiar with, but it's a Toyota manufacturing process. It basically, again, is focused on efficiencies and gaining the maximum amount of value from the care that we provide. Clinical integration is a big focus at Scott & White. Again, having a service area as large as ours and as many providers as we have aligned with the health plan, we feel like we have the opportunity to really take these evidence-based practices and standardize care across a broad geography, and then on the other end of that, prove that that's better. And we've done some of that, and I'll show you that in just a little bit. Our clinical care process redesign and operational improvements. will hopefully help us meet this challenge, because I think we all feel that there's going to be a downward pressure on commercial insurance reimbursement to align with Medicare, and it's going to lower this. The disproportionate share is potentially going to go away. Our indigent care will still be there. We're going to have an addition of new patients to that, and we're going to have to reset this bar basically so that what we do every day costs less for the organization and allows us to care for more patients. So this will be our new break-even point, and we're starting today and have been already trying to meet those goals in anticipation of 2014 when a lot of these changes occur. So what is it going to look like? This is, believe it or not, actually a slide that was taken from a presentation in the Canadian healthcare system, but everybody's focused on this, not just the United States. And so you're going to see a shift basically in hospital-based care, and we're going to have to change our focus to preventative care. It's much less expensive to prevent disease than it is to care for it after it's occurred. And we can't prevent all disease, we know that, but we can shift this curve down, refocus our resources basically on community health, individual prevention. When folks do get long-term chronic conditions, if we can manage those in a more efficient way, we can keep patients out of the hospital, avoid these admissions and this cost. And then, we certainly have some efficiencies to be gained in end-of-life care. Those are difficult discussions, but they're discussions we have to have with our patients to make them understand what the options are, to understand what they want on a personal level, and then try to be respectful of those wishes, because not everybody wants everything. In fact, most patients, in my experience, don't want everything. They want to leave gracefully, and they don't want a burden on their families, they don't want a burden on their communities, and they certainly just don't want to be put through a lot of things from a dignity standpoint. So how are we going to achieve these goals? Again, we have a regional network of primary care physicians, and that's really where the front door to Scott & White is. I mean, that's sort of the basis that we're built on, is our primary care physicians, is enabling them with our network of specialists and our network of hospitals and clinics to care for the patients that they see every day, because that's the front lines of healthcare basically in managing these diseases. We've done some of that already, and I'll show you some slides on. This is just our geographic area, just to kind of give an example of where our clinics are, and you can see we extend all the way out to Mason and some involvement in San Angelo, all the way to Brenham and College Station, up to Waco area, and then of course down to the Round Rock, North Austin area. If we can coordinate services, and that means primary care physicians in touch with specialists in a way that may not exist in other geographic regions, then we've shown that we can reduce the variations. And one of the things that I think the challenge on healthcare providers and on administrators is to try to explain why these regional variations exist. Okay, I mean, you don't have to be a medical professional to understand that if you have the same condition and Dr. X cares for it this way and Dr. Y cares for it this way, and then there's all these other physicians in the middle, you don't know. I don't know if Dr. X is right or Dr. Y is right, but what I know is something is not right, in the sense there should not be a broad variation in how they care for that condition. And so this was a study that's done by the Dartmouth Institute for Healthcare Policy, and basically shows these are Medicare patients, price adjusted per capita in the United States, and it shows the variations in spending across the United States. And the map should not look like this, basically. Again, it doesn't mean that Temple's right or these other areas. These were the least expensive areas that they saw. Now, having said that, the study clearly showed that the quality in these areas was not worse than in the more expensive areas. And so it tells us that we have the ability to care for these patients for less money. These were patients basically in the last 2 years of their life, and as I said, were Medicare patients. If you guys are familiar with Atwal Gawande, he's a surgeon. I think he's at the Brigham, but he's written a number of articles and several books in healthcare, basically, and he wrote the piece on McAllen. If you guys read that, the spending variations that took place in McAllen, Texas, and and really got national coverage. But he says very clearly that there's a bell-shaped curve when it comes to the cost of caring for patients, and there's a bell-shaped curve with quality of outcomes for patients. The problem is when you lay those over each other, they don't line up, and so higher quality does not align with higher cost. In fact, what we're showing is exactly the opposite in most cases, and that's where we need to really change to bend that curve that we talked about for the nation. That's the kind of alignment we're going to need in healthcare. So this is hard to see, I apologize, but basically this is that same study. Last 2 years of life, it's broken down into Texas hospitals essentially, and you can see, well, you may not be able to see, but these red dots are hospitals within the Scott and White system basically that are clustered in this area. And again, the quality of outcomes for those patients was either no different or better. And so it shows us that we can accomplish those goals, and that's where they're focused on when they say there's waste in healthcare, because there is. I mean, we have to be honest with ourselves and say that we're going to have to drive that waste out to achieve these goals. So this review was 306 hospital referral areas. Temple was in the top 10 for quality and controlled cost, showing us that we can do that. So how are we going to expand access? Well, the IT systems have given us a wealth of ways to reach our patients now, and I think you'll see that as the younger patient population comes into the healthcare system. They're more comfortable with email. There's a lot of physicians that still are not comfortable with email communications. I'm one of them. I still get a little nervous about it. There's HIPAA problems and security issues and things like that, but we're going to have to find a new way to reach our patients where they don't have to come into the office for every little thing. Certainly the phone, there's web-based systems. We're already employing the use of health coaches, or what we call vitality coordinators, but they're folks that live in the offices of the primary care physicians and help coordinate care for primary care physician for the patients, sort of trying to begin the medical home process, basically, where patients have people who are looking in on them at home, trying to help them with their day-to-day management, because we all know you go into the doctor's office, the doctor says you need to do these 5 things, you say yes, I'll do that, and you go home and life starts all over again, and maybe you do 2 or 3 or 4, but to get the outcomes you need to do all 5. And if somebody's there to try to help you with that process, then again, we're improving the health of our patients. Focusing on evidence-based care, I mentioned, and then our health plan allows us to do some internal sort of demonstration projects to try to figure out how do we lower cost and enhance care and change up payment systems basically so that we can achieve better outcomes. And then of course, like I said, focusing on the community, on our population-based health so we can make whole communities of individuals healthier. So, I come back to this quote over and over again, and it's probably something that resonates with Darren. I don't know where Darren went, but more than anyone else. But, he's faced with this right now, this same level of consciousness that's existed for decades, basically. And we're not going to be able to solve the problems that are coming and the problems that we have today if we don't really make some paradigm shifts in the way we care for patients. And so, to me, this is sort of the anthem for how we are going to approach things, and we're really going to have to sort of push the reset button on some of our folks in Washington, I think. It doesn't mean they're not trying, and the challenge is not great, but we don't have the option of not meeting the challenge and succeeding. So, all right, I'm going to turn things over to Kevin Leeper, who's going to talk to you a little bit about the rural health clinics and other things. Thank you very much.